So, my slide, my screen visible?
Yes, sir.
Okay. So, in obesity and anesthesia, these are the points that you have to remember as a overall idea about it. Sometimes they may ask you about the definition of obesity. Can you define obesity?
Abnormal growth of adipose tissue.
Normal growth or deposition?
So abnormal deposition of adipose tissue.
You must be very careful with your wordings. It is not a growth, it is a deposition of fat. Okay, abnormal deposition of fat
Adipose
compared to
tissue.
the lean body mass or the muscle mass. Okay, that is called obesity. Very good. The common comorbidities. What are the common comorbidities these patients have?
Diabetes, hypertension.
Why they become diabetic?
Fat deposition in the pancreas, which result in decreased insulin secretions, and they become an inflammatory state, which results in insulin resistance.
So, do all the patients with obesity have fat deposition in the pancreas, or even without the pancreatic fat deposition, can they become diabetic? Are there any other reasons? Is it the only route by which they become diabetic? Direct effect on the pancreas?
No, sir.
What is the nature of adipose tissue? What is the name of the cells forming the fat called?
Adipocytes.
Adipocytes. Okay. What is the role of adipocytes in secreting the hormones in the body? What are all the hormones secreted by adipocytes?
Adipokines, sir.
Adipokines. What are the adipokines? That's the total name is adipokines. But there are subdivisions or individual hormones that collectively they are called adipokines. But what are all the individual hormones that they comprise of?
Leptin, ghrelin.
Leptin, ghrelin, that is regarding to appetite. Then, do they have inflammatory cytokines?
Cytokines. Yes, sir. Tumor necrosis
They
factor,
produce
interleukin 1 and 6.
tumor necrosis factor alpha and interleukin 6 are also produced by that.
Yes, sir.
And what is adiponectin? There is another hormone called adiponectin. I'll show you all the details in a later slide. So these are all the things that are produced. Primarily, that is the reason why they become insulin resistant. First of all, immediately there is no insulin reduction. Insulin production is normal, but they develop insulin resistance much earlier compared to other normal diabetic people who are not obese. Okay, and that is one of the coronary artery disease. Is it common in them? Sudden death is also very common.
Yes, sir.
When do the obese patient can die suddenly?
Metabolic
condition? Did you mention about the metabolic syndrome in your description? You did not do that. That is also an important thing that you have to remember in the OSA and metabolic syndrome. These are the two primary, very, very distressing complications or comorbidities an obese patient can have. The hypertension, coronary artery disease, diabetes mellitus, all these are all very common. But the very dangerous comorbidity that an obese patient can have are OSA and metabolic syndrome. So please try to evaluate the patient with regard to these two particular comorbid conditions, which can result in sudden death. That is the reason why you have to remember that. Then system-wise involvement, pathophysiology, how they develop, anthropometric measures will be asked in the examination. So what are all the various measurements which tell you that a patient is obese apart from BMI?
Broca's index.
Broca's index is, what is that Broca's index?
Height minus 100 in males and height in centimeter minus 105 in females. If
That
it's
is
more
called the
than 10,
ideal body weight. Broca's index or ideal body weight. Okay, that is, you calculate that, and if a person is above that ideal body weight, you can classify, then they say him either he is overweight or obese. Okay, that is the two classification that you can do with the ideal body weight calculation. Then what other measurements are there?
Skin
Waist
fold
Philip ratio.
thickness.
Circumference, waist hip ratio.
Skin fold
Waist to hip
thickness.
ratio, skin fold thickness. Okay, so all these anthropometric measurements also will be asked in the examination too. Apart from BMI, how are the other methods by which you can assess obesity?
Yes, sir.
And all about OSA and metabolic syndrome is very important. And drug dosing principles. This is another thing that the examiners are very fond of asking. So how do you decide what dose to give, whether you have to give on total body weight dose, or whether you have to take ideal body weight, or whether you have to take lean body weight? So what is the basic criteria for deciding the dosage in obese patient?
Depends on volume of distribution and then protein binding characteristics.
It's a lipophilic also.
First of all, you must know whether the drug is lipophilic or
Hydrophilic.
hydrophilic, whether it is water soluble or fat soluble drug. Okay, so if it is a fat soluble drug, what will happen to the volume of distribution in obesity?
Decreases.
It will be increased because there
Increased,
is
sir.
fat everywhere, isn't it? Whereas a water soluble drug will have, even if you
Decreased volume of
give it on total body weight, it will be exceedingly in a high dose for them. Okay, so water soluble dose have to be given on lean body weight basis or ideal body weight basis, whereas fat soluble weight you can give according to total body weight. That is the basic principle. If you understand the concept, then it will be safe for to give the dosage. Especially narcotics, you have to be very careful. If the patient has OSA also, then it is very ill advised to go for narcotic sedation or pain relief, because they can easily go into respiratory failure and airway obstruction and have a complication. Okay. And then what are the challenges in anesthetic management? Clinical situation they encounter. So this is how the whole thing will be discussed now. This is the question that we are given. 26 years old lady with a BMI of 38 posted for abdominoplasty. So first thing is patient's compliance, increasing weight, especially in the abdomen, thighs, and wants to get rid after seeing some ad in the TV. That is how the patients usually come. History taking, what questions you want to ask the patient? Cause of obesity, whether it is environmental, hormonal, or genetic. So if the obesity runs in the family, they have a tendency to become obese. What are all the genes which are responsible for making a patient obese?
Melanocortin,
Melanocortin is one, okay.
leptin and ghrelin.
Leptin and ghrelin, they are all
Mutations.
hormones for satiety and eating. That will come under environmental, not
Thyroid
genetic.
hormone, sir.
Thyroid hormone by hypothyroidism will cause obesity, but that is not a direct genetic. Anyway, I'll show you the other names. And if they have other comorbidities, their duration, treatment, whether it is under control or whether they have complications or target organ dysfunction because of that. Then examine the patient system wise. Start with the respiratory system, especially the airway. Go for cardiovascular system. Look at the endocrine. Look at the GIT, musculoskeletal, and others. Examination. Do a general examination of the patient. You straight away started going to describing the airway and other things. So always start in the exam with the general examination, whether a patient is well built, looks very obese, or small built. So just like how you will describe a patient in your medical examination, you must do the general examination, then go to systemic examination, where you have to talk about the airway, IV access, and spine. These are the three things you must specifically look into. In the airway, you can do about the mouth opening, malambati, neck circumference, neck movement, and anticipated difficult airway. All these things can be described in this. Then IV site is a very important thing, because IV access can be very challenging in an obese patient. And if you are planning for a central neuraxial blockade, identification of the spine would have been very difficult in very obese patient. even to palpate the spinous process, it may be very difficult. And diagnosis, you must make, first of all, mention the obesity class. Don't forget it at all. And then go for the associated complication and say whether they are under controlled level or uncontrolled. Then pre-op investigations, post-op risk stratification is very, very important. And pre-op optimization, what are all the things that you have to do? In that only she mentioned whether the patient is a known ASA and using a CPAP or a BiPAP machine, they should be asked to bring it to the hospital when they come for surgery, so that in the immediate post-op period, it can be applied for them to breathe easily without any difficulty. And then what are all the pre-op instructions regarding the continuation or stopping of drugs, the fasting in elective cases. This, of course, will be an elective case only, the lipoplasty and abdominal section. So whether they will require any pre-op IV fluids, depending upon the nature of the surgery, all that has to be instructed. And intraoperative management, how are you going to place the patient, whether the table will be adequate, whether they require an extra large table, and how are you support the arm, because this abdominoplasty will be done in the supine position. Must decide how you are going to keep the arm, because too much of abduction will be troublesome in this patient post-operatively. And post-op management. So these are the headings under which you must remember to discuss that. Now coming to the, rapidly going through the definition of obesity: abnormally high amount of adipose tissue compared to the lean muscle mass, that is 20% or more over ideal body weight. And the conditions associated with obesity are diabetes, hypertension, coronary artery disease, and decreased life expectancy. Medical and surgical conditions that will be associated with OSA, RSR OSA, obesity hypoventilation syndrome. What is the other name for this? Obesity
Pickwinian syndrome.
Huh?
Pickwinian syndrome.
Pickwickian. It is not Pickwinian, it is Pickwick. There was a character by, who wrote that book on Pickwick? He's a very famous English author who wrote another several books.
Charles Dickens, sir.
Charles Dickens, excellent. Charles Dickens' Pickwick's Papers. That is the title of the book. Pickwick Papers is the book name of the book, where he describes a person with a very huge paunch. The very first sentence is, this man's problem is he cannot look at his feet and wear his shoes. That is the problem for him. That much of a huge paunch he was. And he was always in a rapid shallow breathing with a blue nails, which is called the Pickwickian syndrome. Excellent, very good. So CVS, he has systemic hypertension, coronary artery disease, and CHF, PVD, pulmonary hypertension, hypercholesterolemia, hypertriglyceridemia, hypercoagulation syndromes, and of course again sudden death can happen in CVS. All of you may be remembering, there was a news item in the paper about 5 months ago, where they wanted to do a bariatric surgery in a hospital in Chennai. During induction, patient died. And it became a big of an issue, and the hospital was sealed, and not to, the doctors were sued, and all those things are going on happening. So this, remember, the sudden death is one of the problem that can happen in obesity, especially if they have features of metabolic syndrome. That is the those type of patients are liable to go for sudden death. And endocrine, they may have diabetes, Cushing's, and hypothyroidism. These are the three endocrine problems that may be associated. GI tract, they may have non-alcoholic steatohepatitis. They may have hiatus hernia. This is a very common surgical condition, which may give a false sense of GERD-like thing. However much you give drugs for controlling GERD, if the patient is not getting relieved of that, always look for hiatus hernia. What is hiatus hernia? Virami, do you know
Yes,
what is hiatus hernia?
Yes, sir.
What is that? A small portion of the stomach may get pushed up into the thoracic cavity through the esophageal opening, the diaphragm. Okay, it's by the side of the esophagus. So what will happen? The stomach and esophagus will form a loop-like thing. So there will always be a gastric erosion there, and patient will have the common feeling of GERD despite your proton pump inhibitors and H2 receptor blockers. Whatever you give, patient may still have that problem. So that can be because of hiatus hernia. And they may have gallstones, fatty liver, delayed gastric emptying. Musculoskeletal, they may have early OA, and they may have severe backache. They may develop inguinal hernia, and they can have joint pains in all the joints. And they are more prone for malignancy of pancreas, kidney, breast, prostate, cervix, uterus, endometrium, and colorectal malignancies are very common. And other things, because of the fluid imbalance, they can go in for renal failure. Do they have a, what is the fluid volume in a obese patient? How many ml per kg they have compared to a non-obese adult?
70 ml per kg.
70 ml is for non-obese adult. For an obese patient,
50 to
they have
55.
they have only 50 ml per kg. Okay, they have a contracted fluid state. So you should not rapidly fill up their circulation. They cannot tolerate that. Okay, and because of this slow, reduced circulating volume, any hypotension or any dehydration will precipitate a renal failure in these patients. So you have to do a very balanced fluid replacement in these patients. And psychologically, these patients may go in for depression. This may cause problems in the post-anesthetic period. When they recover, they may cry, they may have throat tantrums, or they may become delirious. All these things can happen because of the preoperative depression they suffer from. And unless they take measures to reduce their body weight, usually the life expectancy is supposed to be reduced compared to the non-obese patients. And pathophysiology, of course, it is mainly because of the imbalance between energy intake and energy expenditure. And fat storage happens in form of dry glycerides and, in these patients. And this triglycerides and the adipocytes, normally up to 40 kg of BMI, that they will have only the adipocytes which are existing in the body, they will increase in their size. But after 40, when they become super morbid obese patients, the adipocytes not only enlarge in their size, but also increase in their number. So normally up to 40, they don't increase in number, but beyond 40, their number also increases in addition to size. And the triglycerides are regulated by an enzyme called lipoprotein lipase. This enzyme is very active in the abdominal fat compared to the fat in the hip or gluteal region or the triceps area. The abdominal fat, which is there in the mainly in the momentum, it contains a lot of lipoprotein lipase, which is very active, and that is the reason why the metabolic disturbances happen in the central obesity patients who have a huge paunch. That is the reason why they develop this problem. And the abdominal fat, if it is increases, it is called the android type. This is also a common question the examiners usually ask. Who will have normally android type of obesity? Men or women? Male patients usually have, and female will have gynecoid type of obesity. So it is compared to the apple and pear shapes to remember the disposition of fat. And waist to hip ratio more than 1 in male and more than 0.8 in female carries a higher risk for IST, stroke, DM, and sudden death. Again and again, I'm telling this complication because you have to remember this so that you make sure that you examine the patient for this possibility by ruling out other complications in them. And stress and cigarette smoking, they stimulate the cortisol production, which enhances deposition of abdominal fat. So in your pre-op optimization, if the patient is a smoker, you must definitely ask them to stop smoking, not only for the purpose of improving the respiratory function, but also for preventing the deposition of increased abdominal fat, which can lead to metabolic syndrome. Similarly, patient who is very stressed should be asked to do yoga or other physiotherapies, psychological therapies to reduce their anxiety and stress levels so that they can, especially those coming for bariatric surgery, these 2 points are very, very important so that you can ask them to control that. Normally, when a patient comes for bariatric surgery, the surgeon will not immediately ask the patient to get admitted and operate the very next day. They will usually see whether the patient can control their diet intake by asking them to go on a liquid diet for 2 months and then stop smoking, stop alcohol usage, and improve their mental depressive state by doing some yoga and psychotherapies, and then only admit them. Because by straight away doing the bariatric, if the patient does not follow the rules post-operatively, there will not have enough weight reduction. The surgery will be a total failure. So you have to remember that nowadays a lot of bariatric procedures are being done for obesity. So this point you have to keep in your mind. And cellular disturbances, what happens is it alters the insulin function. So there is insulin secretion reduction because of fatty infiltration, but more than that, the first thing that happens in them is the insulin resistance. So the increase in adipocytes size causes increase in cytokine release, interleukin 6, human necrosis alpha, and also it decreases the secretion of a hormone called adiponectin. This adiponectin is a powerful insulin sensitizer, which means it makes the normal endogenous insulin activity more powerful. So when the adiponectin concentration is decreased in the blood, then insulin loses its sensitizing effect on the cells, and that is the reason why insulin resistance develops. That is the primary cause. In addition to that, the deposition of fat in the pancreas also decreases the overall secretion of insulin. So the initial process of an obese patient becoming a diabetic is developing insulin resistance due to decreased adiponectin. Later on, deposition of fat in the pancreas also reduces the total insulin secretion, which also aggravates or increases the disease state of diabetes. Okay, that is how the whole thing happens. And the adipose tissues also secreted leptin, which is a hormone of satiety, that it gives you a sense of fullness. After eating a particular quantity, you feel, oh, I am full, I can't take any more. That feeling you get because of this hormone leptin. Is this leptin decreased in obese patients to make them not feel satisfied and go on eating? Is that what is the pathology that is happening in them? Virami?
No, sir.
Is the leptin secretion decreased in obese patients? This is a simple question. Shivashankari, Hiranmayi, Anjani, Sundarya.
Yes, sir. So it includes.
Leptin is not decreased. Please remember that. Just like insulin resistance, there is leptin resistance also. Okay. Leptin is the hormone to give you the sense of fullness. After eating a particular quantity, you feel satisfied. You don't want to take any more. That sensation will decrease because the leptin becomes resistant. It does not have the normal effect that it should produce. but the quantity of leptin produced by the adipocyte is the same. Just like insulin resistance, there is leptin resistance, which is the reason for the patient's overeating. And also there is an increased production of ghrelin, which increases the food intake. So that is the imbalance that is happening between this leptin and hunger producing ghrelin. And genetic factors. There are genes called the beta-3 adrenergic receptor gene. Then there is another gene called peroxisome proliferator activated receptor gamma-2 gene. Then there is a chromosome 10p gene and melanocortin 4 receptor gene. These 4 genes have been identified as the genetic contributors for familial obesity. So this is especially in childhood. Children who are tending to become obese, the mutations, in them, the mutations in leptin and ghrelin secretion is the reason for that. And these children, if you observe them closely, they will be massive eaters. Whatever you give, they will be going on munching and they will ask for more. So in childhood obesity, it is the mutation in leptin and ghrelin, whereas in adult obesity, these are the other genes which are responsible for that. And environment, of course, increased food intake, decreased physical activity, psychological and socioeconomic factors, it's the so-called binge eating disorders and late night eating disorders, especially among the youngsters nowadays. The people are ordering food even at 3 a.m., 4 a.m. One of my relatives is having a hotel, and he says the maximum number of non-veg orders come from 4 a.m. to 6 a.m. So people are keeping awake all the night and eating early in the morning and then going to sleep by 7 o'clock and sleep through 1 o'clock or 2 o'clock. So all these social factors are the reasons for people to become obese. And in the Western world, food packets are all large size, especially if you go to USA, the Lay's chips packet comes in a 500 gram, 1 kg size only. So, and people, once they open the packet, they completely finish it off. That much of eating will be there causing the obesity. Now coming to the measurements used in obesity, first thing is the ideal body weight, which is also called the Broca's index. So they may ask you what is the other name for Broca's index, then you have to say it is the calculation of ideal body weight, which is height in centimeters minus 100 for men and minus 105 for women. BMI, the other name for that is Quetelet's index, 18 kg divided by height in square meters. Then there is lean body mass, which is calculated by calculating first the ideal body weight and adding 20% of that. Then it is called the lean body mass. And this is the classification, how you classify obesity. Our patient belongs to class 2 because the BMI is 38. 35 to 39.9, it is class 2, which is morbidly obese. So always remember to put the class of the obesity in your exam papers. And the other measurements are waist circumference, 102 in male and more than 88 in female. Waist to hip ratio, more than 1 in male and more than 0.8 in female. And tricep skin fold, which is measured using a caliper like this. Do you know the name of this instrument?
Caliper.
Harpenden, Harpenden calipers, very good, right. So clinical criteria for assessing the metabolic syndrome. This is another question they will commonly ask you. There are 5 things that you have to take into account. One is abdominal obesity, where the waist circumference is important to assess the abdominal obesity. Then blood triglyceride levels, if it is more than 150. Then HDL level, which is a good cholesterol or bad cholesterol, HDL.
Good cholesterol, sir.
Good cholesterol. It should be less than 40. And blood pressure more than or hypertension. Fasting glucose more than 110. All these, out of these 5 things, even if 3 are present, that is, will qualify to say that patient has a metabolic syndrome. So in the exam, you have to look out for all these things. If they have given the triglyceride and HDL values, and that means they are expecting you to calculate the metabolic syndrome and see whether the patient belongs to metabolic syndrome or not. Then WHO classification, of course, again the same thing. Adipose tissue distribution can be accurately defined by CT and MRI nowadays. So based on that, you have fact distribution predict risk more accurate than the normal location by physical examination. And of course, sarcopenic obesity is reduced muscle mass and functionality in the presence of obesity. And these people have poor grip strength, and they have history of immobility, and they have slow gait. They are not able to walk fast. So if all these things are present, you can diagnose sarcopenic obesity in them. And preoperative assessment and risk prediction, central peripheral distribution of fat, pressure, presence of metabolic syndrome, peripheral oxygen saturation less than 95 in breathing air. That all signifies that patient is have a little higher risk. And when you try to give emergency medications like noradrenaline or adrenaline, it should be dosed according to the ideal body weight in obese patients. So this is the thing that you have to remember. So always you must know the height of the patient also in obesity, where which you can calculate the ideal body weight as I showed earlier. Whereas dose of atropine you can give according to lean body weight, which is ideal body weight plus 20%. Then there is a scoring system which is given now called OS, Obesity Surgery Mortality Score, where you can calculate the risk involved by knowing the BMI. If it is more than 50, then you give a 0.1 score for that. Male patients have a higher risk, so another 1 point. Hypertension, presence of hypertension, 1 point. And age of the patient more than 45, 1 point. So risk for previous vascular thromboembolism or preoperative vena cava filter indication, or patients having OSA or OHS, right heart failure, pulmonary hypertension, all these things you give a 1 point. So there are totally 5 points, and based on that you can calculate the risk involved in this patient. And coming to some of the ethical and the psychological factors for obesity patients. Obese patients are mindful of society views. They always have a subconscious feeling that people are looking or laughing at them. So this sort of complex will be there in these patients. And your normal theatre gowns given for the regular patients may not be adequately covering them. So you must make sure that the hospital provides good theatre gowns for them to wear without being exposed partly. So appropriate size gowns should be given, and frequent thrombosis risk should be assessed, and prophylactic measures should be taken. And moving and positioning. Normally we bring the patients in a stretcher trolley to the OT. But for obese patients, what they approve or they advocate is if you don't have appropriate equipment and if the patient can walk without any difficulty, then you can ask the patient to come walk to the theatre and position themselves in this operating table. That is the current guidelines and recommendations. So possible patients can maintain their own mobility. They can walk to the theatre. In this particular thing, way back in 1980, when I was doing my MD, we had a 160 kg patient posted for spine decompression. She was a very young lady, 25 years old, but she had a spinal canal stenosis, and the surgeon wanted to do a spine decompression. And the neurosurgeon and the theatre boys could not lift her and put her in the position, and so the surgery was being postponed because of that. At that time, Miller first edition came into market, and in the neurosurgery chapter, they have mentioned that you can do awake intubation in a patient posted like this with morbid obesity and ask the patient themselves to turn and lie in the prone position and then induce anesthesia and continue with the GA. So I sprayed the nostril and oral cavity and explained the thing to the patient and did the awake blind nasal intubation and secured the tube nicely and then asked the patient to position herself in the prone position and then we completed the surgery without any complication. So that suggestion in Miller was tried and I was successful in doing that. So now they are recommending that that patient can even walk to the theater and position themselves on the operating table. And the gel pad should be used to protect the pressure points. And in the absence of any risk factors for aspiration, performing RSI is not routinely required. Earlier, they used to say that most of the obese patients have a tendency for reflex and aspiration, but now that is not being recommended because another reason may be we are giving a 25 to 30 degree head up tilt, which will also prevent the aspiration happening. So that may be the other reason also. And pre-oxygenation is a very, very important thing if you are planning to give GA for this particular, any particular surgery in the patient. Why pre-oxygenation is important in obesity? What is the reason?
To prolong the safe apnea time.
No, that is the benefit that you
Decrease
gave.
the
They have
FRC.
a decreased
They
FRC.
have decreased
FRC.
FRC. Very good. Because of the splinting or upward movement of the diaphragm, their FRC is comparatively decreased compared to the normal patient. Okay, morbidly obese patient may desaturate quickly during apnea because of reduced FRC. This is the answer that we have to give in the exam. And steps to follow, what are all the things that you have to do to prevent this desaturation? Of course, Abhirami went in a lightning style to describe all that. So, but step by step, patient is being pre-oxygenated. First thing, you must always give a head up 25 degree head up tilt. That is the first and foremost thing. Second is, during laryngoscopy, oxygen should be passively administered with a 10 French catheter through the nasopharynx at the rate of 5 liters per minute. So this is continuous oxygen flow with a catheter in the nasopharynx. The third is during pre-oxygenation itself, you can apply 10 centimeters of heat in the obese patient. And lastly, to reduce the occurrence of pre-oxygenation atelectasis, you can also maintain a inspiratory pressure of 55 centimeters of water for 10 seconds after we start the PEEP. So these 4 methods or 4 steps are to be followed to prevent the head up tilt of 25 degrees, continuous oxygen flow through the nasopharynx at 5 liters per minute, application of PEEP of 10 centimeters, and increasing the inspiratory pressure to 55 centimeters for 10 seconds after you have started using the PEEP. And this is the reason why you have to give the so-called ramped up position for a patient to achieve a good ventilation. Because if you see the non-ramped up position, the access is very much difficult to achieve, to visualize the larynx. Whereas if you get the alignment between the external auditory meatus and the suprasternal area or a suprasternal notch, then your mouth opening, your laryngoscopy, your visualization, everything will be here, easy. Now imagine doing a scopy in this, your hand is likely to hit the chest because the patient, especially if they are female and they have a huge breast mass, then it will be very difficult even to introduce the laryngoscope blade. So always remember this position, which is the called the ramp position or head up elevation position, which is HELP position also. Then with regard to pre-anesthetic medication, there are some surgical complications are common in the obese patients. First and foremost is the infection. Surgical site infection is very common. So you must always give a prophylactic dose of 3 grams of cefazolin before you start the procedure, at least half an hour before, so that you get what is called the antibiotic umbrella. which will prevent the surgical site infection. Second is they may have frequent nausea and vomiting, so we can give them dexamethasone, ondansetron, and haloperidol are recommended for this prevention. And pregabalin and gabapentin, melatonin are used for post-operative pain so that they can breathe comfortably. Otherwise, already with the reduced FRC, they are likely to develop atelectasis and other respiratory complications. And TED stockings, and if necessary, if there is previous history of any thromboembolism or deep vein thrombosis, better to start low dose subcutaneous unfractioned heparin or low molecular weight heparin. And lastly, very cautious use of benzodiazepine. As she mentioned, you can give that provided they don't have OSA. In other patients, you can safely give them oral alprazolam or midazolam for surgery-related anxiety. That is also as a anesthetic, pre-anesthetic medication. So these are all some of the really morbid obese patients, how they are transported, how they see. This is imagine if this patient requires liposuction and abdominoplasty. You know what are all the challenges that we may face. And this is the steep head-up position. And you must always, whenever you alter the position, make sure they don't slide off the table by adequate support here, and keeping the arm at the as far as possible close to the body without too much of abduction is very important. And they have given the nice ramp position, and you can see, even though he has a very short neck, the mouth is very easily reachable, and you can easily introduce your laryngoscope. And in the airway assessment, you must always make sure whether you can go for the conventional induction paralysis intubation technique, or whether you have to alter your technique by awake fiber optic intubation at the very beginning itself. This is a very, 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 very important point that you have to decide and document in your pre-anesthetic assessment. Okay. So even if you have a slight doubt about the routine method of induction and intubation, make sure document in your pre-anesthetic assessment that this may be a difficult airway. So plan for awake topical anesthesia and fiber optic intubation, or keep fiber optic intubation ready. There may be a in-between case scenario. It looks neither very difficult nor very easy. In that situation, you can give a trial induction and try to intubate. But if you have an immediate fiber optic or a video laryngoscope, and if you have a senior help, then you can give a trial induction. In even the slightest doubt of securing the airway, never go for the conventional induction, paralysis, and intubation. Always plan for awake intubation after counseling the patient. That will be a lot more safer than trying to do that. And all the questions about obstructive sleep apnea are very, very common in the examination. So what is the definition of sleep apnea?
Episodic and repeated cessation of airflow for more than 10 seconds.
10 seconds. Very good. So already I've shown that. So hypopnea will be there. 50% reduction in airflow. Okay. So what are the types? And if it happens more than 5 times within 1 hour, or more than 30 times for the entire night duration of sleep, that is considered as a very severe case of hypopnea. What are the types of obstructive sleep apnea?
Central
and peripheral.
peripheral.
Yes, you are right. Why are you hesitating? You have central and peripheral, and the questionnaire that is helping to find out a stop bank questionnaire. When will you use this stop bank questionnaire? All of you talk about stop bank questionnaire, but when should one use the stop bank questionnaire?
With a history of snoring, with undiagnosed.
When the patient is not aware that they are having
disease.
OSA.
A life partner will
Okay.
tell the patient.
They say, because patient may not know they are snoring. It is only the family members who are sleeping in the same room will be affected. and the wife may complain about the husband, or husband may complain about the wife that I am not able to sleep through the night because she smokes so heavily here. So that way, in such situations where OSA of a milder degree is present, but patient is not aware of that particular problem, then you can use this stop bank questionnaire to identify whether they are really having a OSA or not. And based on that severity, what is the most important investigation that can be done to confirm your diagnosis of OSA?
Polysomnography.
Overnight polysomnography was the test that was being done. So classified as central and obese, peripheral. The examples of central obesity happens in patients with stroke, hemiplegia, hemiparesis, patients because of drug overdosage or alcoholism. And peripheral obstructive sleep apnea is very commonly seen in the obese patients. And investigations you have to do are overnight polysomnography, CBC, EKG, and echo. Why CBC, EKG, and echo? What information you will get by doing this in a OSA patient?
CBC polycythemia.
Polycythemia, very good.
Echo, we can find out hypertension.
Pulmonary hypertension and right heart failure. Excellent, very good. The treatment for that is lifestyle modification or institution of CPAP or BiPAP and surgery. What are all the surgeries that can be done for OSA? Corrective surgery.
Pharyngoplasty.
Palatouvuloplasty.
So you have to open up the upper airway. Here the pathology is mainly the collapse of the upper airway because of the fat infiltration in the pharyngeal muscles. Once the patient loses consciousness during sleep, they collapse because of the weight. They don't open out. So patient gets an obstructed airway, and after a few breaths of obstruction, there is a hypoxia which stimulates the brain. And there is also hypercarbia which increases the respiration, and patient wakes up with a startle, opens the airway and takes a deep breath and rectifies the hypoxic state. That is what exactly is happening in OSA. So they have tried improving the diameter of the upper airway, the pharyngeal canton, by doing a uvuloplasty, palatoplasty, removal of the tonsil. So all these things have been done to expand the upper airway so that patient does not have a collapsed upper airway. And the anesthetic risk in OSA patients are they are very sensitive to narcotics, and they will desaturate much faster if you are not taking adequate precautions. And unless properly investigated, they may have biventricular failure also because of the long-standing OSA and the pulmonary hypertension. Now, this is the stop bank questionnaire, which all of you may be aware of. The snoring, whether patient feels tired in the morning after overnight sleep, whether anyone has observed them getting a choke or getting obstructed, and whether they have increased blood pressure. This is the stop bank, STOP. Bank, body mass index, age, next circumference, and gender, which is they are mainly male patients. And what is the algorithm to follow? If you say screening is done, step 1, whether stop bank 0 to 2, low risk. Stop bank 3 to 4, intermediate risk. Stop bank more than 5, high risk. So this is based on the stop bank questionnaire. You can classify them as low risk, intermediate risk, and high risk. And if it is intermediate risk, low risk you can ignore. People who mildly snore without desaturation, without a startling wake up, all that, you can ignore that. But again, in the post-op, you have to make sure that you don't sedate them or give too much of narcotics. And in the intermediate risk case, you go for whether they have this additional problems, whether they belong to the male BMI neck circumference, and then see whether they have a high risk. If they have high risk, then go for the polysomnography and assess the severity by observing how many episodes of obstruction happens and what is the lowest limit of desaturation that is happening. So based on that, you can classify the severity and start the therapy like CPAP or BiPAP. So that is the whole idea. And so this is what is called the Berlin questionnaire, where the other things about snoring, the details of snoring is asked. And in the category 2, there is the same first two things about tiredness, waking time, and all these things are asked. So this is another thing, but commonly not used in regular practice. But just if the examiner asks you what are the things that is being examined in Berlin questionnaire, just for that you can remember these few points. And you must maintain the safe apnea time in all these patients who have been diagnosed with OSA. And that is how the thing that we earlier discussed, the steps that we have to follow, that will take care of all these problems. And OSA with daytime somnolence is called OSA syndrome. So patient who is very sleepy during the daytime because of the repeated obstruction and waking up in the night, then they tend to sleep in the daytime, which is called the OSA syndrome. And with regard to the drugs, you have to first classify them, as I told you, into lipid and water soluble, and based on that you must decide what to give. The few drugs which we use on total body weight, this chart is important. Propofol for maintenance, you have to give on total body weight. That is, if you are going to do IV infusion of propofol throughout the surgery, then you calculate it on total body weight, so many milligrams, that is 1/10 of the induction dose. Whereas when you want to do it on for the induction, for example, this patient of ours who is BMI is 38, probably her body weight is say 130 kilos. You don't give the induction dose as 260 based on 2 milligram per kg. So 120 into 2 will be 240 milligrams. You don't give that much. On the contrary, you first calculate the ideal body weight, add 20% to that, and then decide the dose, load the dose that is required for induction. So for induction of propofol, it is only the lean body weight. For maintenance, you have to take total body weight. And midazolam being a fat soluble drug, you have to give it only on total body weight. Similarly, the relaxant dexamethasone is also given on total body weight. Cisatracurium for loading, you give on total body weight. For maintenance, you use the lean body weight. This is the opposite of the propofol. And panchronium, of course, nowadays not used, so you can ignore. But propronium, remifentanil, and sufentanil are all given only on lean body weight. Even though these drugs are all fat soluble drugs, you don't give them on total body weight because they are potent respiratory depressant drugs. Coming to vascular access, that may be challenging in these patients. So you have to sometimes resort to central line placement. If peripheral veins are not at all visible or not accessible, you have to go for a ultrasound guided central line placement. And in volume replacement, avoid rapid rehydration because they have, as I told you, lesser percentage, total body water. So fluid replacement in obese patients should be based on
Lean body weight.
lean body weight rather than total body weight. So that is the thing that we have to remember. Challenges in anesthesia. This is the mnemonic I've been telling for all these batches. You remember this mnemonic, a prime minister at a public function. So the A, P, M, A, T, P, F. This is all the things that you have to remember that. So the first A stands for airway. So detailed evaluation and planning is very, very essential. Whether you are going to do a conventional induction paralysis intubation, as I told earlier, or whether you are going to plan for awake fiber optic intubation. Then the position, how are you going to position the patient, whether you have the adequate size table and whether you have facilities for giving the head up tilt in the table, or whether you have to use the sheets and other supports on the back and the head to make the ramp position or the held position. That has to be decided. Monitors, what monitors are you going to use? NIBP cuff size, which she mentioned. If you don't have the extra large cuff, you can always use it on the forearm just below the elbow, especially if the artery line, which is in the cuff, which many of you would have noticed, should be on the radial side, so that the radial artery pulsations are easily picked up compared to the ulnar side. And if it's very difficult to tie the BP cuff, you may have to resort to invasive arterial line, especially when the surgery is a major one and you cannot depend on the non-invasive method. And temperature monitoring is also very, very important, especially for abdominoplasty and liposuction. They tend to become hypothermic, and if they have hypothyroidism, their recovery will be very much delayed. So it is always safer to monitor the core temperature also in these patients by a temperature monitor. And agents that you can use safely are the volatile anesthetic agents. Desflurane is recommended nowadays, and you have to calculate the drug dosage, as I said in the earlier slide, about the lipid soluble and the water soluble drugs and the total and lean body mass. And the neuromuscular blocking drugs, when you use them, you may need to monitor the neuromuscular junction function also. And what anesthetic technique you are going to use, that also you have to decide, whether GA or regional. And for GA or regional, first in difficult IV access, you must decide how you are going to secure the IV access. And surgeries which can be completed within the duration of regional, we can definitely go for a single shot spinal. Or with the challenges in the technique, you can also sometimes perform a continuous epidural in these patients, but it is requires a lot of skill to correctly identify the space and the catheter and achieve that. And pain relief, you go for less narcotics and go for multimodal analgesia incorporating most regional technique. And fluids, you just based on the lean body mass and avoid rapid filling, which I said earlier. So these are all the 1, 2, 3, 4, 5, 6, 7 things that you have to remember. So this mnemonic, I hope, will be useful both for your exams as well as for your day-to-day practice of and managing the obese patients. And the airway management, already we have seen that always better to go for tracheal intubation, but of course with the availability of third generation LMAs, people are using LMA also in the management of the airway in these patients. And patient position, head and arm position, monitoring ventilation. This is just to show you how you can tie the PP cuff in the forearm. And you can use a neuromuscular block, monitoring agent. And you can use ultrasound nowadays to secure the IV line. So this is how the picture will look like. This is a blood vessel and the needle is entering here. So they have secured an IV line using the ultrasound. And the same ultrasound is used for identifying the intervertebral space also in obese patients. So you can see this is the spinous process. They look like two humps here, and a gap between that is the interspinous space, and we can approach that with the use of ultrasound. And clinical situations, sometimes you may have a simple case like a obese patient having a fall and fracturing in the hand, so needs reduction, and if needed a K-wire fixation. This is, and the patient may be in full stomach. So this is how the case scenario can be given. So what will be your technique if this is the case scenario? What is your choice first for a wrist fracture for a K-wire fixation?
Blocks, regional block.
Regional.
Block.
Upper limb block. That is the answer. Okay. Upper limb block. Either you can go for a supraclavicular block or a axillary block. But axillary block, they may have a lot of axillary pad of fat. So it may be very difficult to palpate the axillary artery. So ultrasound guided supraclavicular block will be a very good technique so that you can safely avoid airway manipulation. You cannot worry about the full stomach and all those things. But in any regional technique, the bottom line is you must be ready to convert it to GA in case the regional technique fails or if it wears out halfway through the surgery. Okay. So without the guarantee of ability to convert to general anesthesia, purely depending upon regional will be a foolish act. Sometimes you may be getting caught in between, especially sometimes the surgeons do bilateral knee replacement. You may say, I am a very fast surgeon, I will finish in 2 hours. You just give a single short spinal. So sometimes you get fooled by that and you start that. You will get stuck halfway through, and for one knee itself, you will take 2 hours. By the time the effect of the spinal will start wearing off, and he will insist that he will do the other side also. So that sort of situations can happen if you are not confident enough to convert it to GA. So that is always you must keep it in the back of the mind that you should be able to convert it to GA without any problem. And the other scenario is a smoker, COPD, lot of comorbidities, diagnosed with CA rectum. He is again class 2 morbid obesity, treated for OSA, and in what investigation needed, how to optimize, and what problems anticipated. So this is another problem question that may be asked. And the next thing is undergo weight reduction surgery since all conservative methods fail. So this is a classical case of bariatric surgery. And super morbid obese lady with a huge non-reducible incisional hernia posted for hernia repair and abdominoplasty. This is similar to the question that we have seen. So, the management strategies, 62 years, every analysis of such cases are always look at the age and see whether they belong to geriatric age group. In that so that means the additional problem of geriatric comorbidities. And calculate the BMI if it is not given. If they just give you height and weight, you must always be ready to calculate the BMI. And see the nature of the surgery, whether it is emergent or non-emergent. Preoperative evaluation, you must do a thorough evaluation of the airway, any history of OSA, comorbidities, and whether they are under control or not. And for the wrist fracture, whether because the surgery is non-emergent, you can advise pre-op starvation and do it as an elective. And the RA will be preferred technique over GA. So it can be supraclavicular block, axillary block. Even IVRA also can be a choice if the veins are good. LA injection into the wrist hematoma is also one of the techniques. And for first and second, that is axillary block and supraclavicular block, we can use US guided techniques. And if the patient refuses to cooperate or doesn't want a regional or doesn't want to be awake during surgery, then you have no other choice to go for GA, and all the routine preparations of GA are important. So this small procedures done as a daycare, so evaluation is very important, and all facilities for admission should be present. And The second case scenario is a malignancy, CA rectum. So you don't have much time to prepare or optimize the patient. That is the answer that's expected there. So with all the attendant complications or comorbidities, you have to sometimes ERAS protocol also will be included with that for the rectal surgery. So the plan of anesthesia may be GA or regional with epidural or tap block or paravertebral block, rectal stitch block, etc. And it's not moving fast. So remember the mnemonic for GA. For bariatric surgery, the third case is a laparoscopic procedure. The patient is young, but they have diabetes. So airway, OSA, and the glycemic control are very important. And the technique for bariatric surgery nowadays recommended is IV infusion with dexmed and ketamine. That is being recommended as a, instead of inhalational agents with desflurane, dexmed and ketamine infusion with controlled ventilation is the technique that is being recommended. And for incision hernia repair, of course, it can be done under regional or can be done under GA with a tumescent local infiltration to improve the. This is how the abdominoplasty before and after surgery. Okay? This is the pendulous abdomen for which the surgery is being done. So just to give you an idea how it is effective. Obese parturients, sometimes they may ask you questions on obese parturients. So there you have to have a multidisciplinary team for better management. Neuraxial analgesia should be offered early in labor. Continuous neuraxial techniques are optimal for cesarean delivery. In always the obese patient, there is a risk of general anesthesia in these patients. Of course, I will not go further. The slide is not moving well. I will just stop here. There are problems of that. Okay. So these are the things that you have to remember.